Okay, so let's talk about acute kidney injury, or AKI. This is, without a doubt, one of the most common problems you are going to see in any hospitalized patient. It's this sudden, pretty serious drop in kidney function, and you have to think fast. So let's dive in. We're going to break down how to tackle this whole thing like a clinical detective, from spotting that first clue all the way to solving the case.
All right, picture this. You're starting your morning, you pull up the labs, and bam, there it is. Your patient's creatinine, that key marker we all use for kidney function, has shot through the roof. It's doubled overnight. That's the exact moment the clock starts ticking. The rest of this guide is all about answering that one single critical question. Okay, now what?
So, first things first, we have to officially define the problem. We need to know what we're looking for. And for that, we use what's called the KDGIO criteria. These are basically the global rules of the road for kidney disease. Now, what's really important here is that it's not just one thing. It could be a small but really fast jump in creatinine, or it could be a bigger jump over a week. Or, totally separate from labs, it could just be that your patient stops making much urine. Any one of these is enough to say, yep, we've got AKI.
And if you're thinking this is some rare thing you'll hardly ever see, think again. About 1 in 5 adults admitted to the hospital worldwide will develop AKI. That number really tells you why getting good at this stuff matters so much. This is a problem you are absolutely going to see, and you're going to have to know what to do.
Okay, so we've made the diagnosis. We've identified that we have an AKI. The very first step is to figure out just how bad it is. See, it's not just a yes or no question. There are levels to this. We've got to size up the problem.
So, the same criteria that we use to diagnose AKI also help us stage it, from a stage 1 all the way up to a stage 3. And this isn't just for paperwork. Staging is really important because it helps us guess a patient's risk and tells us how aggressive we need to be. And take a look at stage 3. It's not just about lab values anymore. It also includes starting renal replacement therapy, dialysis. That tells you you're in the most severe stage.
All right, now for the real detective work. We have to line up the usual suspects. And here's the key to solving pretty much any case of AKI. The culprit almost always falls into one of 3 big categories.
The easiest way to think about it is like this. You have prerenal, which is a flow problem. There's not enough blood getting to the kidneys in the first place. Then you have intrinsic, which is a filter problem. The kidney tissue itself is actually damaged. And finally, you have postrenal, which is a plumbing problem. Urine is being made, but it can't get out. This simple framework, flow, filter, plumbing, is seriously the most powerful tool you have for organizing your thoughts.
Let's start with our most common suspect, prerenal AKI. This is the cause for something like 70% of cases that come in from the community. The issue here is just decreased perfusion, which is just a fancy way of saying not enough blood is flowing to the kidneys. The kidneys themselves are actually fine for now, but they're thirsty. They're not getting the blood they need to do their job. This can be because of real volume loss, like from vomiting or diarrhea, or it can be from something like heart failure or sepsis, where the blood just isn't circulating effectively.
Now, this is a fantastic example of how a common medication can be the bad guy. So when the kidney senses low blood flow, it has this brilliant protective mechanism. It releases chemicals called prostaglandins that basically open up the inflow artery, the afferent arteriole, to let as much blood in as possible. But what do NSAIDs, like ibuprofen, do? They block prostaglandins, so they take away this protective shield, and the artery that's supposed to open up actually clamps down. And just like that, the filtration rate tanks. It's such a key point. In a vulnerable patient, a totally normal medication can tip them right over the edge.
Okay, suspect number 2 in our lineup is what I like to call the inside job. This is intrinsic AKI. So here, the problem isn't the flow to the kidney anymore. The damage is actually in the kidney tissue itself.
Now, intrinsic is kind of a bucket term for a few different things, but just look at this chart. The vast, overwhelming majority of cases in the hospital, we're talking around 90%, are from one thing: acute tubular necrosis, or ATN. This is where the actual tubules, the real workhorses of the kidney, start to die. The other causes are definitely important, but ATN, that's the big one.
So what causes this inside job? Well, it usually comes down to 2 main culprits: ischemia and toxins. If that prerenal state of low blood flow goes on for way too long, the thirsty kidney becomes a damaged kidney. That's ischemic ATN. Or the kidney can be directly poisoned by stuff like IV contrast dye or certain antibiotics. You can also have other causes, like a drug allergy causing inflammation in the kidney tissue. That's called interstitial nephritis. Or an autoimmune disease attacking the tiny filters, the glomeruli. These are less common, but you got to keep them in mind. And that brings us to our final suspect, the blocked getaway, or postrenal obstruction. This is that plumbing problem we talked about. The kidneys are working, they're making urine just fine, but the urine simply has nowhere to go.
So the blockage can happen literally anywhere, from the kidney all the way down to the urethra. The classic example is an enlarged prostate in an older man. Or it could be a kidney stone, a tumor, or even something as simple as a clogged Foley catheter. The reason we always have to think about postrenal causes is because they are often the most fixable. You find the blockage, you relieve it, and poof, kidney function can snap right back to normal.
Okay, so we've got our lineup of suspects: prerenal, intrinsic, and postrenal. The flow, the filter, and the plumbing. Now, how do we figure out which one is the real culprit? It's time to open our diagnostic toolkit and start gathering some clues.
Your investigation always starts with the fundamentals. The history is huge. Are there any clues that the patient's lost a lot of fluid? Did they just start a new medication that could be toxic to the kidneys? Then, your physical exam gives you clues about their volume status. And this is a big one. A simple bedside renal ultrasound is the fastest, easiest way to look for hydronephrosis. That's a swelling of the kidney that basically screams obstruction.
Now here's a classic clinical pearl, a real pro tip that is so useful. When the ratio of the blood urea nitrogen, or BUN, to the creatinine is greater than 20:1, it is a massive clue pointing towards a pre-renal cause. And why does this happen? Well, in that low-flow state, the kidney is desperate to hold on to water, and urea just kind of gets pulled back into the blood along for the ride. So the BUN level goes up way more than the creatinine level. This table right here, this is the heart of your lab investigation. It's how we tell the difference between a thirsty but healthy kidney and a truly damaged one. So in a pre-renal state, the kidney is just conserving. It's holding on to everything it can. So the urine sodium is low, and the fractional excretion of sodium, or FeNA, is low. But in intrinsic ATN, the tubules are broken. They can't reabsorb sodium, so it just gets dumped into the urine. And the urine sediment? In pre-renal, it's pretty clean. But in ATN, you see the classic muddy brown casts, which are literally just clumps of dead kidney cells. Finding those is a smoking gun for ATN.
So to wrap up our investigation plan, it all starts with good old-fashioned clinical skills, history and exam. Then you use your lab clues to tell the difference between a flow problem and a filter problem. And please never ever forget to rule out a plumbing problem with an ultrasound right at the beginning.
All right, we've gathered our clues, we've identified the culprit, our investigation is pretty much done. Now what? Now it's time for action. What's our first response?
The management flows right from your diagnosis. If it's prerenal, you have to restore the blood flow. A thirsty kidney can turn into a dead kidney real fast, so you cautiously give fluids or support their blood pressure. For any type of AKI, you have to stop any offending drugs. I mean, you can't put out a fire if someone is still pouring gasoline on it, right? So get rid of those nephrotoxins. If it's postrenal, well, relieve the blockage. And for every single patient, you have to be on high alert for the dangerous complications, especially a dangerously high potassium level.
Let's just hammer home a few key principles here. The number one goal is always to treat the underlying cause, and this is a really crucial point. Diuretics do not fix AKI. They can help you manage a complication like fluid overload, but they do not treat the kidney injury itself. You've got to avoid drugs that are known to harm the kidneys, and hey, don't ever be afraid to call for help. Get your friendly neighborhood nephrologist on the phone when things get tricky.
You know, this famous quote has never been more true than when we're talking about acute kidney injury. Treating it is one thing, but stopping it from ever happening in the first place, well, that's the real win.
So we're going to leave you with this challenge. You now have the detective's guide. You know how to diagnose and start managing AKI. But honestly, the most important skill you can have is spotting the patients who are vulnerable before their creatinine ever doubles. So think about the patients you're taking care of right now. Who has the risk factors? Who's on those meds we talked about? Thinking one step ahead like that, that's where you're going to make the biggest difference of all.